Did you know that prediabetes is extremely prevalent in our population, in fact, worldwide, and that having prediabetes can cause some serious health risks? Yeah, I didn't either, and that's why we have a doctor in today to talk all about it. And plus, the most important question, if I am prediabetic, does that mean I'm going to become a diabetic? I'm Sarah King, and I have a lot of questions. Hormone replacement therapy. Will that increase your desire to want to have sex? You gotta get that protein. Get that protein. Ladies, you need the protein. Do you think it's been exaggerated? If I have sex the night before my pap smear, can it mess up my results? In this show, I get to ask WakeMed doctors any question I want, and bless their hearts, they have all the answers. Sarah Has Questions is a production of Mix 101.5 and Capital Broadcasting Company, and it's presented by WakeMed. We are going to talk about pre-diabetes today, and we are having another comeback, which is very exciting. Welcome back, Dr. Mike Soboeiro.
Thank you.
And I'm excited about this episode because you're so excited. When we finished our last episode with you, you were like, listen, if you need another topic, I want to talk about pre-diabetes. Why are you so passionate about pre-diabetes?
Because this is a huge problem. This affects more than 100 million Americans. There are only 350 million of us.
So
and this
third of
affects
us.
a third of us. And if you look at adults, it's closer to 40%. And, you know, we talk about important topics that affect a couple 100,000 people or 1 million people, right? This affects 1 out of 2 people over 65 and 40% of adults. This is a huge, huge issue that people don't know enough about.
Well, okay. Yeah, I would agree with that. Considering the statistics, it's very shocking. So what exactly is prediabetes?
Okay. So I'm going to try to do this as untechnical as possible.
You want
right?
to layman it for it. Lay it
I'm
on
gonna
me.
try to make
Layman it on me.
Try to make it as easy as possible. Okay. So prediabetes means your blood sugar starts going up, right? Starts increasing. Now, the issue is, though, that is a late change, not an early change. Prediabetes is not an early indication of disease. It's a late indication of disease.
Okay.
Now, why do I say that? The underlying problem is insulin resistance. We have a large amount of insulin resistance in our population. Much of it is genetic, okay? So if you're somebody who's not insulin resistant, right, you make about 20 units of insulin a day in your pancreas, and that keeps your blood sugar perfect, right? When you're insulin resistant, what happens is you start making more insulin. So your body's making 30, and then it's making 40, and then it's making 50. But your blood sugar is still perfect.
Oh, but the pancreas is getting worn out.
But the pancreas is getting worn out. And when your blood sugar starts to go up, that means your pancreas can't keep up anymore. And so that's not an early problem. That's a late problem. Insulin resistance is manifest for at least 10 years by the time someone is diagnosed with prediabetes. So the process has been going on for years prior to the sugar starting to go up. When the sugar goes up, that's a 5-alarm fire.
Yeah.
Okay?
What is causing your sugar to go up? Why are you becoming insulin resistant?
So first of all, there's a lot of genetic insulin resistance in the population. Some more so in some ethnic groups than others. We talk about Pima Indians. We talk about certain Hispanic groups that have more insulin resistance. So why? Interesting why. So when thousands of years ago, when we were foraging for roots and nuts, we didn't get meals regularly. And becoming insulin resistant was protective, right? Because insulin metabolizes glucose, right?
Right.
So back then, since we weren't taking in a lot of glucose, being insulin resistant and metabolizing glucose more slowly was protective, okay? But we're not foraging for roots and nuts anymore.
No.
We're going to Burger King and McDonald's.
Right.
So it's not protective. Now it's harmful. And so that's why there's so much insulin resistance in the population. Then you combine that with sedentary lifestyle and high carbohydrate diet, and you have an epidemic.
I see.
That's what we've got.
And would you say that Americans, because you always hear, are Americans the ones in the world that have the most prediabetes in their population?
Really not true. It's everywhere.
Okay.
I mean, some country is better than others, but it's everywhere. This is a global problem. The statistics I'm giving you are for the U.S., but it's true all over the globe.
Okay, interesting. Are there any symptoms that can tell you you're diabetic?
No. So
Oh, well, that's
when
great.
when your sugar is not super high, you're
Right.
not having symptoms from high sugar. So this is something you really have to go and get tested for or screened for. What we really need is we need an insulin resistance test that one could have as a young person to say, hey, Sarah, you have this level of insulin resistance, so you're at risk, so you need to watch it. But we don't have that. We don't have that technology yet. We have some experimental ideas, but nothing.
Oh, interesting.
Nothing that's applicable to the population yet. But I think we'll get that, and that'll be huge.
Okay, I want to get to testing in a second. I do want to ask one question about diabetes itself, because I'm assuming, well, let me ask this. If you are pre-diabetic, does that mean you are going to become diabetic?
So about 5 to 10% of people with prediabetes become diabetic each year.
That's a surprisingly low statistic.
It's not high, but we're talking about each year now. But also, there's a lot that you can do to prevent it. So let me give you one statistic. If you lose 6% of your body weight when you're diagnosed with prediabetes, if you lose 6% of your body weight, decreases the chances of becoming diabetic by 75%.
Ooh.
So we definitely can intervene. Prediabetes is a late complication, but it is not too late to intervene. But what we do is important.
Yeah, absolutely. That's incredible. 6%, 75% less chance. That's amazing.
Right.
Why is it so dangerous to have diabetes?
Okay.
What does it do to the body?
All right. So now I got to get another little technical discussion here. Okay.
I love technical.
Okay. So there are two main categories of complications of diabetes, what we call microvascular complications and macrovascular complications.
Micro small, macros big.
You got it.
All right.
So it has to do with the size of blood vessels.
Okay.
So microvascular complications are eye disease, blindness, kidney disease, loss of renal function, and nerve disease, neuropathy. Okay. So those organs are all affected by these tiny blood vessels. Okay. Now, with microvascular disease, the higher the blood sugar, the more disease. So if you have somebody who's had diabetes for a long period of time, poorly controlled, they have a higher risk of those microvascular complications.
Okay.
The lower you get those patients' blood sugar, the fewer the complications.
Okay.
Now, macrovascular disease, large blood vessels, heart attacks, strokes, peripheral arterial disease. Okay, those are those complications.
What is peripheral artery disease?
When you get blockages in your legs, the big
Okay.
arteries in your legs or your arms, and you start to walk and you get pain.
Okay.
So these are all macrovascular complications. The two big ones are heart attack and stroke, right?
Okay.
Okay. Those are not related to the level of blood sugar necessarily. Those are related to the underlying insulin resistance. The insulin resistance itself is a risk factor for macrovascular disease. So that's why this is the kicker. Pre-diabetes puts you at risk for those almost as much as having diabetes, which is why we need to know if we're pre-diabetic and do something about it, right?
Okay, so you are at more of a risk for a stroke or a heart attack or what is it, deep vein thrombosis?
Not it's a different vascular disease.
Oh, it is.
But you're more at risk for those type of complications,
Interesting.
specifically heart attack and stroke.
What is it about the insulin resistance that puts you at risk?
So I don't want to get too technical about
well,
that one, but insulin resistance is an inflammatory condition, and inflammation causes changes in the blood vessel that can cause blockages, that can cause stenosis of blood vessels, and that's where heart attacks and
I know what
strokes come
stenosis is. That's like making it more narrow.
You got it.
Okay.
You got
That
it.
is fascinating.
Yep.
Okay. And if you have diabetes, the disease itself, you'll have risk of both. But if you just have prediabetes, you'll have risk for the macular ones.
Well,
the macro ones, rather.
You have more risk of macrovascular complications, right?
Yeah.
And so we've got a problem that affects 100 million Americans.
Yeah.
That only 20% of people know they have, and increases the risk of heart attack and stroke, which are still the highest risk of death or debility in the United States. So
there's a correlation here.
And that's why I'm saying this is such a problem,
Yeah,
right? That's
yeah.
why we need to know this is the case and do something about it.
Okay, so I'm 48 years old, right? Is there a test right now? I know you said there were some tests that you can take. Like I know you have a glucose test. Will that show you if you're pre-diabetic? What about I hear about A1C tests.
Right.
So what's going on with these tests?
So the most sensitive test you can get for this issue is an A1C test.
And what is that?
So it's a masterful idea. So your red blood cells live for about 3 months in your body. Okay. So 3 months and then they go away. They're replaced by new ones. Red blood cells carry glucose.
Okay.
Their main function is to carry oxygen, but they also carry glucose. In somebody with normal glucose tolerance, about 5% of your red blood cells at any one time have glucose attached. The higher the percentage of red blood cells with glucose attached, the higher your average blood sugar over 3 months.
Fascinating.
So that's how A1C works. So we use A1C to diagnose, and we also use A1C to follow people with diabetes. But it's the most sensitive indicator of somebody with prediabetes. If your A1C is between 5.7% and 6.4%, you're in that prediabetic range.
Gotcha.
If it's over 6.4, you're in the diabetic range. If it's under 5.7, you're in the normal range. That's the most sensitive test. Fasting glucose helps. So if your fasting glucose is less than 100, it's normal. Between 100 and 125, prediabetic range. Higher than 125, diabetic range. But A1C is a more sensitive test.
Wow. Okay.
And you can get A1C anytime.
Well, that's my question. Is like I mentioned my age, because at what age should I start asking? I mean, are they part of a standard physical? If I were to make an appointment with you, because you are a primary care doctor, if I remember correctly.
Correct.
And so if I were to get a physical with you, is that an automatic test, or do you do it at a certain age, or should everyone just always be asking for one of these?
So, I think it's not part of the standard rubric yet, right? We have the U.S. Preventive Services Task Force.
You got there.
They act slowly based on data. This data is still accumulating. A lot of this stuff is new and cutting edge. But I do an A1C test on just about everybody, specifically people who are at risk. Why would you be at risk? Family history of diabetes, obesity, other cardiovascular risk factors. But I do them, pretty standardly, because it's such a meaningful test, and there's so many people out there.
Right. That makes sense that you would. So when you say genetics, and if it's in your family history, how far back in your family history? Because I have a great-grandmother who had diabetes, and no one's had it since then. So is it immediate family? Is that considered family history, or does it go further than that?
I don't think there are hard and fast guidelines. Certainly a first-degree relative, mother, father, sister, brother with type 2 diabetes would be the biggest risk. Right. I often go back to the grandparents, because some young people, their parents aren't necessarily old enough yet to have gotten a lot of medical care.
Right.
But so I go at least to the second generation.
That makes sense. And you mentioned obesity as well. I've heard that, and I think this is the right term, adipose fat, is that what it's called? Which is the fat around your midsection. Is where you carry your body weight also a telltale sign? Because I've heard that it kind of does does relate.
I don't know the data. I know what you know, that central obesity is more important than peripheral obesity. I can't say I pay that much attention to that.
Okay.
I think the important point, though, is that fat is an organ. Fat creates hormones.
Wait. Slow down. Fat's an organ?
Well, it's not characterized as an organ, but it is a metabolically active substance, right? Fat creates hormones. Fat creates inflammation. Fat is an active substance. It's not just sitting there doing nothing.
This is revolutionary to me. I didn't know that.
The fewer fat cells, the better. I'll give you some examples. I know you do a lot of issues with women, right?
Yes.
Women with a higher fat mass make more estrogen. They menstruate earlier. They get pregnant earlier. They're at risk for pregnancy earlier. Why are more women getting pregnant at younger ages? Because there's a higher incidence of obesity than there was 20, 40, 50 years ago. So fat does things. Fat creates inflammation. Yeah.
Sorry, I'm like reeling over here. I never thought about fat being an active substance. You just think it's like just there. It's just like whatever it is there. And also, I know that fat with the hormones can cause PCOS.
Absolutely.
Yeah.
Absolutely.
Wow. Woof. That's new to me. Sorry. You just blew my mind. So once you have diabetes, is there any chance of ever kickstarting your pancreas to start again?
Well, most people with type 2 diabetes still make insulin, right?
Okay.
It's where you catch them in this whole progression. And you really can think of it as a progression from insulin resistance without prediabetes through diabetes, right? So wherever I'm catching people on that spectrum, what I'm trying to do is make them more insulin sensitive, right? Because there's the insulin resistance component, And then as you become diabetic and you're diabetic for longer, there is the lack of insulin component, right? And at some point, people lose the ability to produce insulin, and then there's only one treatment, which is insulin. But the vast majority of people we catch with type 2 diabetes are still making insulin. And so what you're trying to do is make them more insulin sensitive so they can use the insulin that their body is making. And that's what you're doing with prediabetes.
Okay.
You're trying to make those patients more insulin sensitive.
Does the pancreas have a set amount of insulin that it can make over its lifetime? Or does it just get tired because you're making it work super hard all day long?
I don't know that you can say that it has a set amount of insulin to make over its lifetime. I think every individual is different.
Right.
But I do think, over time, if you overwork the pancreas, you poop it out.
Okay. Oh, good to know. So what can I do to keep myself from becoming pre-diabetic or possibly reverse the pre-diabetic condition I may have?
Right. So, parts 1, 2, and 3 of treating prediabetes have nothing to do with medicines. It's diet, exercise, and weight reduction, right? And when we say diet, it's staying away from simple carbohydrates, because simple carbohydrates, unopposed simple carbohydrates, right?
What does unopposed mean?
Just eating carbs by themselves, okay? So not eating a mixed meal. So I'll give you an example with myself. Where I got into a lot of this is I had an A1C test. It wasn't pre-diabetic, but it was darn close. And I said, how could that be? I exercise all the time.
Right.
So I put a continuous glucose monitor on myself, which you or anyone else can do because they now can be bought over the counter without a prescription.
I think it's called.
Dexcom Stelo.
Oh.
Stelo, Stelo.
Dexcom
Stelo.
Dexcom Stelo.
So I put a continuous glucose monitor on myself. And what I saw was that when I ate a mixed meal, a little fat, a little protein, a little carbohydrates, even if I had dessert with dinner, my blood glucose was fine. But if I ate unopposed carbs, and that meant going to the coffee shop and having a cinnamon roll by itself, my sugar shot up. So I clearly have some insulin resistance. Not a surprise. My grandmother was diabetic, right?
Okay.
But that's there. So how do you fix that? How did I fix that? Mixed meals, fewer simple carbs, less sugar, less bread, more mixed meals, more protein, more vegetables, more salad, less bread, less sugar.
Yeah, what you hear all the time, just cut back on sugar and carbs, which are essentially the same thing when your body gets a hold of it.
You've got it. You've got it.
Okay.
And then exercise plays a huge role. Exercise, very helpful.
How much exercise? Because, do we have to go to CrossFit every day? Or can I get, what do you mean by exercise?
Sure. So the easy answer is do as much as you can. Do as much as you're able, okay? But the hard answer is that every time they come out with exercise guidelines, they increase them because the studies show the more exercise, the healthier, right? So they used to say, 150 minutes. Now the current guideline says 150 to 300 minutes a week. And the reason is that that's what the studies show help. They show 300 is better than 150. More vigorous exercise is better than more moderate exercise. A mix of moderate and vigorous is better than moderate itself. It just keeps showing that the more exercise, the better. And not just for this condition, for just about
lot,
everything.
Yeah. I hear it from every doctor that sits in that chair. They are always like, gotta exercise. Okay, and then you said the third one was lose weight, which is not the easiest thing to do. In fact, it's nearly impossible for a lot of people. There are those GLP-1s that are popular right now, and that's a whole nother podcast that I can't wait to do.
Right.
Because I have so many questions about that.
Let's just talk for a minute about drugs, though.
Sure.
Okay. Because there's only one drug that's been approved for prediabetes, and that's Metformin. And Metformin is an old medication, been around a long time, very nice medication, been around 60 years, inexpensive. Honestly, it's not the best treatment for prediabetes. So the best treatment for prediabetes is GLP-1s. They are extremely effective for prediabetes, but not approved for prediabetes. Why? Because of the cost. Think about 100 million people taking expensive drugs like that,
We'd
right?
have to have a GLP-1 factory in every city.
Oh. And I'm not saying everybody with prediabetes needs a GLP-1. I'm not saying that at all. What I'm saying, though, is that if somebody with prediabetes really needs something, that's the drug class that works the best.
Right. Well, and that's what it was initially put on the market for.
For diabetes.
For diabetes, not prediabetes.
Right.
This has been fascinating on so many levels. Fat is active, blowing my mind. Almost half the population has prediabetes, and this is globally probably. this was fascinating. Thank you so much for taking the time today. And I really hope this spreads far and wide. And I know I'm going to ask for an A1C. I have a physical in a couple weeks. I'm getting an A1C.
Yes, definitely get an A1C. See where you are. It doesn't mean you need one every year. I mean, if it's normal, it's normal. But there are a significant proportion of people that have borderline A1Cs, higher A1Cs. And it's good to know because then you can do something about it.
Yeah, you don't have a stroke or a heart attack. That's great.
Right.
Thank you so much.
Yes, very welcome.
I just had my mind blown so many times. First of all, the fact that prediabetes is so prevalent. I mean, 40% of the adult population, that's insane. And you can bet your bottom dollar I'm going to be asking for an A1C for my next physical. And the whole thing about fat being an active substance, mind blown. If you have questions about prediabetes, head to wakemed.org. And until next time, take care, everybody.